Next speaker, Dr. Ali Abbas Hasham. Welcome to the stage.
Thank you, Jess. That was an excellent presentation. No pressure, huh? You guys can't see, but there's a clock here. It's quite stressful. Can you hear me okay? Yeah. I do apologize. I mumble. I speak very fast. You know, GP 10-minute appointments. So forgive me. Firstly, thank you to See the Science for the opportunity to, one, provide the software and actually do the work, but to come and present. Secondly, for the opportunity to wear my three-piece suit. It's the first time I wore it, and my wife now calls it the cancer suit. You can see my lovely titles on there. I just want to clarify, I am no longer the Harrow cancer lead. Dr. Bushra is coming on next, has kindly taken on the mantle and all the hard work that goes with it. Yeah. But I don't believe titles define us. And I just want to give you a little bit of where my motivation comes from. So my 16th birthday, 4 days later, my father passes away with a sudden heart attack. Right? Shocking, right? I know. But it really brings life into perspective. Death is inevitable for all of us. The quality of life is our choice. What we do in the meantime is our choice, and legacy is our choice. And from that day on, it really opened my eyes that, you know, I'm a bit cynical. I said, okay, I got to 42, I got to do what I can with my life, and that's my main driver. When I got married, I told my wife, you got 20 years, then I'm off. She wasn't too impressed. Oh, clicker, sorry. So before we crack on with this, mine's a bit the unsexy governance side of things and how we can improve patient outcomes. But I was admiring this lovely portrait behind us, and I'd just like you to come with it with me. You've got the lovely GPs and clinicians on the pedestal, completely inaccessible. You've got the security guards, our modern-day dragon receptionists. You've got the old man on the modern-day or period-appropriate wheelchair. You've got the children, the minstrels, the hippies, the politicians, the horses, the modern-day Ferraris, yeah? And then you got me right at the back, and I got Sanjay here as my operations manager. Right at the back. See the statue there behind the GPs? That's us. That's the organizations that run the NHS. That is our responsibility. So, I love IT, I love AI, I love patients. So how do we make it work? So the problem we faced, so I came in as a partner in 2022, but I was a salaried GP in the practice from 2020. I qualified as a GP in 2020. It was very manual. We were dependent on people to remember things and make sure that things were happening. Very challenging. People, as amazing as they are, do forget. They have their own stresses. They're not as dependable as computers sometimes when you have to do the same thing again and again. So we recognized as a partnership that there's a risk here, especially when it comes to cancer. There's nobody who will tell you cancer is not important. It has to be done on time as quickly as possible. So all the statistics. So we recognized these human factors, and we started looking around. It just so happened I became the Harrow Cancer Lead. It just so happened I heard about See the Science, which was fully funded by my ICB, but I'd never heard of it up to that point. So that was the problem. How do we digitize it to make it better for patients, for our staff, and reduce the workload in the process, right? Everybody wins. So we identified See the Science as a good product. I tested it. I was told it was invented in our PCN when B was a registrar at Honeypot Lane. So even more pressure that this has to work. What's the next slide? Okay. So how did we implement? I think if there's any lesson you'll take away from here is that any software is only as good as you will implement it, only as good as you will make an effort to make sure it works. And that, whether that's feedback to the people providing the software, whether that's training for your clinicians. To give you an idea, we're a practice of 10,000 patients. And I had to sit with every single clinician, including partners, and spend 20 minutes explaining how to use this piece of software. And that's the only way it got implemented. Everybody says, yeah, we'll do it. Yeah, it's fantastic. Nobody does anything until you take the time and make sure it's implemented properly. We had practice meetings. We put it on our Teams channels. I then told my secretaries that if anybody does a single cancer referral without See the Science, I need to know. And then I go and talk to that person. This is not punishment, but this is highlighting that you need to do what I tell you. But See the Science allowed us to standardize it. I don't know if you've used EMIS before, but it is extremely hard to find forms if you don't know what that form is called. It's extremely hard to know if the form is up to date. And the hospitals regularly complain when I was cancer lead that we're using outdated forms and not providing the information they need to process the referral. So standardization. By doing the referral through See the Science, it automatically goes on a dashboard. So nobody has to remember to keep track of something on an Excel spreadsheet and then to check that has the referral happened, have they attended clinic, what was the outcome. Dashboard made it really easy to get all that done. Finally, then you have the niceties of sending leaflets in different languages, and it's really straightforward, and it gets saved into emails automatically. So all of that was lovely. I'm sorry, I keep forgetting I can see it here. So by doing that, we improved the process, and then we gave ownership to administrators to say, okay, you two are now responsible, so Sanjay in the back, for making sure that we make sure patients are being seen. We live in an age where patients have become numbers on our systems, and it's really easy to lose them in that system. So we must take the ownership that patient cannot be responsible for everything. And I will share some stories in the next slide. But effectively, you were referred by the GP. Do you understand how serious it is? Did you get seen in the clinic? What was the outcome? Do you want to speak to a GP afterwards when you're diagnosed, maybe? Right? So all of that came through our safety netting process. For the partners, when we have our partnership meeting every week, we just wanted to look at a glance. Where are we? Are things happening? Are things going to plan? Are we doing what we're supposed to do? We just so happened to have a CQC inspection, blown away. They were beyond impressed at how we utilize the software to get to where we need to be. So put everything in one place. Everybody follows the same process. All the doctors follow the same process. All the administrators follow the same process. What happens when someone picks up the phone from reception? They know exactly what the process is. So when the patient says, I haven't had an appointment or I don't know what to do, everybody knows what they're doing, and this is a scalable model. By the way, in my area, everybody seems to have 3, 4, 5, 6 children, so our numbers are just escalating. So we need a scalable model. We're clearly not very good at contraception. So when, I must admit, I did these slides very last minute, but just a few stories I could remember. There were 3 referral forms that were done by the doctor, but they forgot to task the secretaries to actually do the referral. Because of that, the administrator picked it up literally within 12 hours. It was not missed. It was sent off. Feedback was given to the doctor. They improved their process. They did their own reflection, improved their CPD. Fit tests. You know, we have a policy of 5 working days for all results. Fit tests are now picked up literally the day after they come back because we can use the software. We have a very challenging population because of language barriers. They don't always understand the significance of things that are giving to them. So that particular patient, when he left that appointment, he had a urine test, a stool test, a blood test, an ECG, an X-ray, and he did everything, but he didn't do the stool test. It's not important. Why would I catch my poo and put a stick in it and all the rest of that? It's nonsense. And in his language, of course. My administrator, without me telling her, picked up the phone and said to him, where is this test? It's been a month. He's like, oh, I got it sitting at home in my drawer, so bring it. Like, no, I don't want to do the whole poo thing and this and that, She was able to explain to him, as a non-clinician, the importance of this test. It came back positive, he got referred. Thankfully, he didn't have cancer. But the point is, we didn't miss it. So, to summarize, it works, all right? The safety netting is better. We have the tools now for oversight, for good compliance. CQC is happy, which means partners are happy, which means ICB is happy, which means cancer is happy. The efficiency. I am actually saving staffing costs because we can do things faster and more efficiently, both from the doctor's perspective and the administrator's perspective. And finally, team morale. It's really surprising that our staff feel like, because of these little things, we're doing a better job. We're actually providing a better service. And in the mess that the NHS can sometimes be, we're actually doing our bit to get as far as we can. And with that, I hand over for questions.
Great, thank you so much. Any questions from the audience at all?
By the way, I'm within 10 minutes, yeah?
Yeah, you've got plenty of time for some hard questions. Got one over here.
Hi, fascinating discussion, thank you. Regarding the efficiency that you have found, have you quantified that and perhaps been able to ascribe a value from a health economic perspective? And if so, if not, would that be something you might consider?
Do you mean value in terms of cost saving or in man hours? Or?
Yeah, so in terms, what is the value of the efficiency that you've found in terms of cash or hours?
So I know my senior partner was very happy when we did the maths. So if I had to guess, being very honest, we used to have 2 different people doing one for cervical screening, one for sort of fit testing, and then one would do secretaries would do the referral. So by amalgamating 3 roles into one, there's definitely time saving there. If I had to guess, I would estimate between 2 and 5 hours a week, if that makes sense. But more importantly, the output was much more reliable. Before it was like, you're in charge of fit testing, I have to trust your opinion, and then go look through your complicated spreadsheet, and now it's much more, I can just look and I know that things are happening. And that was the greater value rather than the actual cash saving, if that makes sense. Yeah.
Thank you.
Yes.
So I'm an A&P in primary care, and we have a very, very similar process. In fact, we've got a poster downstairs showing our process. And we definitely found the use and see the signs has made our process extremely slick.
Nice.
In terms of money, in terms of time, of course, I'm not a partner, so I don't care about that. But what we actually recognise is that the patient experience is fantastic. All our patients get letters, they get business cards with a direct number to secretaries, so they get straight to the person that they want to speak to. And yes, it's just really just to sort of say we're doing the same things up north as well. So I'm really glad to see that you've been able to improve services like we have as well. So I think it's quite good.
Excellent. Let's give a shout out to your practice. Where are you from?
So we're from Barnsley.
Barnsley, excellent.
Yeah.
Amazing work.
Yeah.
Well done. I'm going to steal that word slick. I like it. Yeah.
I know. So just come out, so have a look at what we...
Can I ask the secretary's number? Is your direct secretary or the hospital secretary?
No, direct to the GP practice secretary.
Okay, nice.
So when she gets that call, she comes and tells me the patient's asking for some pain relief. No problem. The patient gets seen the same day.
I can see Sanjay is fretting because normally I give his number out. Yeah.
I know it is time consuming, but the thing is though, those patients it must be so scary to have that cancer diagnosis and think, well, that's it then. I can only speak to the hospital. No, you can't. You can speak to us, you can speak to district nurses, Macmillan, etc. So I'm glad that
thank you for that. I'm going to take that on board and think about how we can implement it. Yeah,
thank you.
Great. Okay, we'll move on to the
There's
next
just one
one.
here,
One more question. Yeah, sneak it and go. Yeah, microphone.
If you say I can, okay, let's go.
Thank you. We do the same process, and it's amazing to hear. So thank you. So as a GP, so I manage 9 GP partners, and they are really good at adapting to change, actually. So it's wonderful. I guess the sort of question I've got really is how to use the slick word just to make it a bit better, because, for example, they use it, but then there was some other GPs the other day that said, oh, I didn't realise that you could give leaflets at that time or fill it in at that time. What they're tending to still do is, refer after the patient's left the room or task themselves and then use see. So they're definitely using see the signs. So all our evidence, and we've got a poster downstairs, and that shows that, and we've safety netted. So for us, again, yes, it's made time savings because we instruct our secretaries like you do to sort of push back, but I think really it's just that, how do we get that process slicker with the GPs to sort of, some do it a bit later still, some do it, but once it's on, it's on. So.
Yeah. So I'll just be clear that there's no right answer with any of this. Every organization is quite unique. People are different. You have to play the people factors, right? So I have very tech-savvy partners and very non-tech-savvy doctors as well. So we always operate on the model of who's the least tech-savvy person, and we sort of force that level of mandatory usage of software, if that makes sense. The 20 minutes I told you I sat with everyone, I showed all of them all the features. Now it's up to them to use. As long as they're doing what the organization needs as a basic, then everything else is extra. So the leaflets, for example, is a good idea. But nobody should have the excuse that I didn't even know that that feature existed, right? One of the things I like to see the signs is they send updates that we've made these feature improvements, because often the software looks the same, but there's new features available. So recently, like the dashboard was updated, for example. So I had to sit with the administrator again just to explain, by the way, this is, and one small point is that your administrators will often not realize why they're doing what they're doing. So we found that spending half an hour explaining what a fit test means, what the outcome is, what happens in hospital, things that doctors take for granted, makes a huge difference, because suddenly they realize, oh, this is actually quite important. And then they take even further ownership, which is all you can ask for from people. Yeah, but thank you, it's a great question. All right. I'll leave it there.
Great, thank you very much.